Assalamualaikum warahmatullahi wabarakatuh and very good afternoon. Hello everyone. Thank you organisers for introducing me and thank you to Jawatan Kuasa Perlindungan Sinaran Hospital Pengajar UPM for inviting me to present at their diagnostic imaging course on optimizing radiation and image quality. So today my topic is radiology audit on high quality image production, roles of radiographer. So with my 19 years experience as a radiographer, ranging from clinical to managerial positions, inshallah I will share my auditing and image quality producing experience with all of you. Today's agenda, I will cover start from introduction to radiology audit, and then the roles of radiographers on high quality image production. Thirdly, suggestion for improvement, and lastly, the summary and action items. As I mentioned earlier, I will start with the introduction of the radiology audit. So, why do we need an audit radiograph? Firstly, to identify deficiencies or non-compliance with the radiographs produced so that improvement and preventive actions can be taken to improve the quality of services. Secondly, to ensure that the radiograph produced meet the quality standards set by the Ministry of Health Malaysia or your hospital itself. And thirdly, to ensure that the radiograph produced have a high diagnostic value so that any pathology can be detected more accurately. So the point is here, improvement and prevention actions meet the quality standard and have a high diagnostic value so that any pathology can be seen in your radiograph. Okay, this is why the radiology need audit. I would like to share an article from Dr. Chen Schilberg, 2017. It's about the need for clinical audits in diagnostic radiology. He said that a clinical audit should follow generally accepted rules and standards. The document explains. It should be systematic and involve continual activity whereby the recommendation given in audit reports are actually implemented. Uh, So, what is the objective of clinical audit? The objective is to improve the quality of patient care, to promote the effective use of resources, to enhance the provision and the organization of clinical services, and finally to organize professional education and training. I would like to share this book published by IAEA, Comprehensive Clinical Audit of Diagnostic Radiology Practice, a tool for quality improvement. They call it QADRIL. There is a guideline to do audit in radiology department. So in this book, by comparing the practice of the service against the standard of good practice, clinical audits can inform the staff of the healthcare services, which is us, as well as the other stakeholders, which is vendor company, about the essential elements of quality and the weak points of the overall clinical service. The audits will indicate areas for improvement and provide reassurance on issues such as safety and efficacy, all of which are essential to creating an environment of continuous development. So I just want to highlight there is a book guideline for us to do or to perform audit in diagnostic radiology. So the question is, how can radiographers conduct a radiography audit on their own? I think radiographers should be familiar with this PASMAN. PASMAN is a technique for radiographers to determine if a plain film radiograph is high in diagnostic quality. It was devised in the 1980s by Roger Windle in Adelaide, South Australia, to help other radiographers and students have a structured way to critique radiographic images. At that time, Pac-Man's video game was the reggae, and it just so happened that the first letters of the areas identified as important to critique made up the acronym PASMAN. It has been widely used since then. So, PASMAN is one method to perform audit by radiographer itself. To perform audit, we need a guideline. So this is one manual, program jaminan kualiti QAP dalam khidmatan radiologi, which have guideline for auditing radiograph. In this document, QAP implementation manual, there are radiographic audit elements as shown in the table, which involve the chest X-ray for adult, extremities for adult, lumbar spine for adult, and chest X-ray for neonates, and abdomen for neonates. There is four parts in audit form for image quality assessment, which start with image annotations, patient positioning, image collimation, image quality assessment. As I mentioned, there is four part in audit form, but the first one in image annotation is a mandatory. Mandatory meaning that if the film or image have the patient identification, date of examination, name of clinical or hospital, primary anatomical marker, so it can proceed to the next part, the next three part. But if the image fail in the first part, so the next part no need to continue, and we will give them 0 marks, meaning that the image is fail to comply with the image quality assessment audit. For the first audit, involve chest X-ray adult. The second part will be the patient positioning. They will look at the symmetrical positioning of thorax, the medial border of the scapula to be outside of the lung fields. This is two criteria need to be fulfilled. And the third part is image collimation, and the fourth part is the image quality assessment. So the total marks will be 15, but to pass, they need to achieve at least 12 scores. I would like to highlight finding from the first audit form, chest radiography adult. The most common non-compliance by radiographers are the first one, radiographs have no permanent markers or inverted markers, and then second, collimation cut off. Third, the scapula is in the lung cavity in the radiograph. And fourth, there is rotation on the radiograph. So this is the most common mistake that we are doing. We go to the second form, audit form, which is extremities adult. As I mentioned earlier, the first part is mandatory. If pass, we can proceed to the next part. So the second part is positioning. Correct region of interest must be included in the radiograph. Two appropriate projections for extremities radiograph, kena ada dua. So part 3 is collimation area, and part 4 is the optimum exposure, which visualize the shape of trabecular and cortical outline and trabecular pattern, and appropriate visualization of soft tissue outline, and proximal and distal joints to be included. Maksudnya for the long bone lah especially must include two joints, proximal and distal joints. Let's take a look finding from audit in extremities for adult. So the most common non-compliance by radiographers found radiographs have no permanent markers. Number second, collimation cut off. And number third, performing only one projection. So this is a mistake by human or by equipment. Think about it, okay? The next audit part is lumbar for adult. After pass the first part, we proceed to the second, patient positioning, and collimation must include superiorly T12 or L1 and inferiorly L5 or S1 joints, and laterally must include SI joint and source muscle outline. This is criteria for AP radiograph, okay? So the next one, image quality assessment, spinous process at the midline of the vertebral body, and the lateral one, superimposed border of vertebral bodies, okay? And Optimum exposure should clearly visualize the vertebral body and joint space without overexposure of other vertebral structures. So this is the criteria need to fulfill to pass the audit of lumbar for adult. So what is the most common non-compliance for lumbar audit? There is radiograph found with no permanent markers. And secondly, collimation cut off. Yeah. Next is chest criteria for neonate for budak-budak. So this one I will not touch detail about it. I just proceed to the next. And the next criteria in audit form in manual QAP is abdomen X-ray for neonate. So I will not go detail about it, just to give you an idea what is audit criteria or assessment include in the manual QAP. Next is reject or retake analysis. So this also include in manual QAP or KPI, department KPI. So this document reason for rejection or retake must be recorded in document, and the reason of the reject or retake. What is the difference between reject and retake? Reject normally we use for the all processing images with using the dark room, and retake this one is for CR or DR. The reason is the same. So this is the type of error caused by the human faults and equipment. So we categorize the image which under human faults, whether the image is overexposure or underexposure, double exposure, wrong technique, wrong patient, no primary or wrong marker, collimation area cut off, or patient movement. And if it's equipment failure, equipment fault is under equipment, which is the, related to the X-ray tube, grid, bucky, detector or imaging plate, image artifact, processing fault, and miscellaneous. Sorry. From this slide and next slide, I will show you the example of reject or retake radiograph, which, as you know, that we need the optimal or high quality images to meet the standard quality that we set up, and to give that high diagnostic value so that any pathology can be detected in radiograph accurately. That's why this one, as you can see here, because of the reason of the human fault, overexposure and underexposure is unacceptable. That's why we must reject or we must retake the radiograph. This is example of double exposure. Because of double exposure must be rejected. Why reject? Because if you can see the image in the images, chest X-ray of neonates baby include in the cervical X-ray of adult. And secondly, chest X-ray and abdomen of neonate include in the chest X-ray adult. So this is not acceptable, unacceptable. So cannot be diagnosed. Cannot be diagnosed. Must be repeat or retake. This one is must be a simple understanding. Wrong technique. As you can see here, very bad technique. The movement and processing error that you must reject or retake. Okay, this is a human fault under wrong patient or exam. It can be wrong patient because of the same name, or you change the form in the clinic or hospital in the ward. We already have that experience. The wrong form of examination given to the wrong patient, which the surname dia the same surname, but the father's name is different. That's why we need to ask two ID of patients, name and IC numbers at least. And then wrong examination. It can happen. Ordering chest X-ray, but you did perform abdomen X-ray. Also, this also cannot be accepted. This is the reason why we need to reject or retake. Next, under human faults is no primary or wrong marker. So this is criteria. You need to use the primary anatomical marker. Cannot use digital marker or cannot pass film without marker. This is the common mistake made by radiographer, as previously you can see in the slide. Next, reason of retake adalah collimation error under human faults, or also under human faults. So the images appear here show that the cut off the region of interest, so must be rejected, yeah, or retake. This is the example patient movement. Yeah, human falls under patient movement. As you can see, the blur images of lumbar spine and shoulder. So we can write down the report that these images are rejected because of patient movement. This is the images under category equipment fault. The first one, the grid line appear in epicervical, which X-ray beam are not aligned with the grid line. And the second one, the detected drop. This one, the white band appear on images obtained after a detected drop at the above area of chest X-ray. Okay, this is of the example of detector or imaging plate error. The first one, detected drop chest radiograph obtained with a portable radiographic unit, show two types of artifact. A large white smoothly edged defect, horizontal arrow here, and appear at top left, and straight line vertical arrow are seen across middle of the image. These artifacts appeared on image obtained after multiple detected drop. Banyak kali berlaku. Okay, the second one, here you can see multiple white specks above the clavicle. This is the example of the error. Reject or retake because of image artifact. This one, the first one cannot be accepted because it appear in the region of interest, chest area, the chain, so must be repeated. And the second one, you can see the inhaler and button here. So also in the region of interest, so we need to repeat. Okay, this is the example of processing fault. This is not very often occurred. This is very rare because of the use of the old film in X-ray. Okay, this is the example under miscellaneous, which is foreign body. The first one, if the coin is outside body or there is no history that patient swallow the coin, so you need to repeat it. If let's say the history is to see the coin that swallowed by patients, by their children, so no need to reject lah. The second one, the earring, PG, and the third one is spec for OM view of the skull. So there must be a reason for reject, and there must be a justification to accept the images. Okay, I would like to share an article written by Owen Buanga. Last year, he published this literature review, cause of reject and repeat of digital radiographic images. The 6 causes of rejection and repetition of digital radiographic images were identified as: the most popular one is patient positioning errors. The second one, inappropriate selection of technical exposure factors. Third one, patient motion. Fourth, presence of artifacts. Fifth, improper collimation of the radiographic beam and absence of permanent anatomical site markers. So if the first one, patient positioning errors, meaning that whether we actually have enough educate our staff or we lack of knowledge, so we need to improve, like suggest by the previous writer, the need for radiology audit. If you can remember that you need audit to get the proper training and education. Okay, this is another study in last year, 2021. Digital radiography reject analysis of examination with multiple rejects and Australian Emergency Imaging Department clinical audit. So in this study, from 11,596 images, show overall reject rate was 10.3%, and the overall multiple reject rate was 1.3%. The projections with both a high number and high percentage of reject were epi chest, it's about 18.1%, epi pelvis 22.5%, hip 33.5%, knee 30.5%, and the projection with both high frequency and multiple reject rate were knee and hip. So the top reasons for multiple rejects were positioning. So this study result same with the previous study in the same years, in at the different area, and anatomy cut off it about 8.4%. So meaning that we need to educate our radiographer properly position the patient, must be careful and must be very concentrated and focused when we are doing our job. I think communication will help us improve uh, image quality. Although that sometimes, if we get the talkative patients, waiting them to stop talking is like very stressful, and also they keep asking whether the X-ray is not dangerous. Is this the cause of cancer? Where we feel that they can ask in the clinic, but they are macam eager to ask us in department why I should do X-ray. So this is kind of stressful for radiographers, but we need to entertain them because they are our clients. You need to be smart to tackle this situation, so that you can be patient while handling that patients. The reason I talk about communication because I found this paper from Singaporean radiographers, which they tackle the issue to achieve fully inspired chest X-ray for patients. They have highly rejected radiograph because of not achieving fully inspired chest X-ray. So because of this language barrier, they start using the audio recordings so that the patient familiar with the language they use, uh, so they can follow the instruction. So it increase, yeah, actually the rejects is decreased, yeah, from 26% to 9%. So which is biggest achievement, yeah, for this audio recordings invention. 92.3% of the chest X-ray taken within this period also fulfill the criteria of fully inspired chest X-ray, as evidenced by having at least 9 posterior ribs seen above the right hemidiaphragm. So this paper they share and to evaluate, how radiographers tackle this issue and continue to acquire the fully inspired chest X-ray for the dormitory residents despite the language barrier. So, which is very interesting, a simple study but very meaningful. Okay, I would like to share this article, how audit can help you reveal the quality of your radiography. So, in this paper, the audit process has four main components they highlighted. First one, setting a standard. What should we are doing? Observing our current practice, what are we doing, and action plan to meet the standard. What do I need to do be better at radiography? And number four, evaluation, re-audit. How do I know I am better at it? So this is the question you should ask if you do audit. Yeah? And the report from the audit can be mainly bullet points and contain the following. Why you are doing the audit, the standards, targets, and exceptions, method used, sampling, data capture form, who was involved in the audit, collected result with analysis or discussion, action, plan, and re-audit. That, So from the report, from the components, process of audit, we can do the preventive improvement and preventive actions. So, what is a clinical audit? So we keep asking. We have the manual, we have the standard. We need to meet the requirement and standard that we set up. And in clinical audit, what can we found from that? So I have the example of previous clinical audit did by our department, which is presenting in a poster. So I would like to share a few topics related to radiography. Okay, because we need to involve radiographers in the department, so we do research day. In research day, we start with clinical audit. Every unit must submit the form and performing clinical audit to see the problem occurs in their unit. Yeah, to tell other radiographer, this is what happened, and this is the way how to improve, to give them awareness that cannot do the same mistake as previously. So this is the topic we have done previously, a clinical audit positioning of CT brain for neurosurgical patients in Neuro CT Suite, Hospital Kuala Lumpur, and a clinical audit of optic lens involvement in CT head imaging for Siemens MS CT scanner in Radiology Department, Hospital Kuala Lumpur. This is the example of next unit, which is audit about the anatomical markers usage in radiograph and about the positioning of the bilateral knee. So they highlighted the mistake and they show to other radiographers. So hopefully they will not repeat the same mistake. Okay, this is the next example of clinical audit about exposure factor and screening time. So if you perform the audit, you do some data collection, so you can answer to other people. Like first one, you can answer whether radiographer actually push button simply or within the normal range of exposure while using CR or DR. So the second one, what is the screening time for the venoplasty, which you can answer to other person. This is the range of screening time, whether you can refer to the guideline from outside, whether it's acceptable or not acceptable, whether it's within the range or not. So you can compare it with other study. Yeah? Why is it important to produce optimum or high quality diagnostic radiographs? Think about optimum or high quality diagnostic radiographs. One of the most important responsibilities of radiography practitioners as radiographer to provide the best possible radiograph for reporting. Because image quality is subjective, it is difficult to describe. So uh, we must make sure that the radiograph we produce, the image that we produce, can make an accurate diagnosis to the patients. We go to the next one, roles of radiographers on high quality image production. I just want to start with the international patient safety goal. What is sixth goal of patient safety? First, identify patient correctly. Second, improve effective communication. Number three, improve the safety of high alert medication. Number four, ensure correct site, correct procedure, correct patient, yeah, performing the procedure, and reduce the risk of healthcare associated infections. And number six, reduce the risk of patient harm resulting from falls. So this is the standard internationally that we have to know, that is our goal to achieve. Okay. When it get busy and all the requests come in at once, you see the patient queue long outside the department, and so many business lah that there. So you must remember, you must achieve the six goals previously I mentioned. So cannot do mistake, okay? But still you have to ensure that you manage your time and manage patient very carefully. Ask yourself, what are my main responsibilities as technologist or radiographer? Your responsibilities and duties are to identify the patient, inform the patient, inform accompanying persons, verify that the female patient is not pregnant, contribute to the preparation specifications for new equipment, participate in optimization of imaging protocols, perform the radiological procedure following an optimized protocol and ensuring patient protection, perform regular quality control of radiological equipment, take a record of patient doses, and inform the radiologists and radiation protection officers in the case of an accident or incident. This is just to remind us what is our responsibility. Okay, that is our responsibility. If we are not sure, we are referred to other person, like our superior, our friend, our colleagues in radiography, before we performing the procedure. So we also can refer to a book. So this is the book, which is very good in positioning to critique whether the radiograph accepted can be accepted or must be rejected. The radiographic critique by Katie McQuillan. In the book, there is a critique form you can use for to start a clinical audit. Yeah, this is the idea whether you can take one positioning and do a clinical audit about it, and then you can see whether you can accept the image or you can reject the image. Yeah? This is the criteria highlighted by the Katie McQuillan. You can use it as to improve the practice. Okay, this is to share that there is SOP about our career from U29 until 52, if I'm not mistaken, in this book that you can search in the website of Allied Health Science Division, Ministry of Health, Malaysia, uh, as your reference and guideline. Okay, this is the example of the book. SOP standard for the radiology services, radiography, and mammography. Okay, this is another book about fluoroscopy, angiography, and interventional radiology, about CT scan and MRI, which you can search in the website. I just want to highlight here, so SOP, general radiography, they also suggested to use Passman method for radiographic critique. Okay, there is also highlighted in the SOP about how to control and to improve the quality. So this is suggested in the book. You can use as a reference. You also can take this idea to do the clinical audit. So what is image quality? Review factors affecting image quality. Okay, it is the exactness of representation of the patient's anatomy, with adequate optical density in film or signal in digital, and minimum unsharpness, optimum radiographic contrast, and no artifacts in the image. Okay, why is it important to get a high quality image? Because good image quality will ensure the maximum amount of diagnostic information is gained from the image, and the visibility of the radiographic image depends on two factors. The first one is the overall blackness of the image, and the second one, the difference in the blackness between the various portions of the image. So important the clarity and sharpness of the image as to present the subject. So what are four factors affecting image quality? The first one is density, the second one is contrast, the third one is detail, and the fourth one is distortion. So what is density? Density is the overall brightness of the image. It's referred to as the radiographic density or optical density. When the radiographic density is optimum, the image is both dark enough and light enough for you to see the anatomic details clearly on the view box. Density is controlled by exposure factors, primarily the MAS. In increase in MAS, it results in a darker radiograph, while a decrease will cause it to be lighter. The prime controlling factor for density is MAS, and the influencing factor are KVP, SID, beam filtration, beam restriction, body part thickness, and grids. Okay, the skull X-ray shows the MS effect to the exposure. So change in MS will alter the quantity of exposure to the image reader. Increase MS will increase the quantity exposure. Decrease the MA will reduce the quantity of exposure. If the MS double, the quantity of exposure also double. Okay, number two is a contrast. What is contrast? The difference in the optical density of adjacent structures within the image is referred to as a radiographic contrast. So image here show the high and low contrast image has a black and white appearance. Structures in the gray areas are easily distinguished, but no details can be seen in the very dark or the very light portions of the image. So the low contrast image has an overall gray appearance, and the structures tend to blend into one another. So difficult to differentiate what type of anatomy nearby. So the optimum red contrast image show detail with all area of the image, although the contrast in some areas is less pronounced. So we should perform the optimum contrast. The prime controlling factor in contrast is KVP, and influenced by subject contrast, MAS, SID, beam filtration, beam restriction, and grids. How KVP controlling the contrast? High KVP produce a low contrast image, and low KVP produce high contrast image. So we radiographer as a radiographer uh, assign the KVP using our exposure technique chart, and this KVP is predetermined based on the penetration needed for the part and the contrast required according to body part of examination lah. Therefore, KVP is the primary controller of radiographic contrast. The third factor affecting image quality is image detail. This refers to the sharpness of the image. When the detail is high, the edges and lines that make up the image are crisp and precise. With low detail, these lines and edges are less distinct and appear somewhat blurred or out of focus. So the example of the wrist joint, the first one is poor detail and the second one is good detail, which you can see the trabecular pattern of the small bone here. The factor that affect detail image are motion, SID, focus spot size, OID, and image receptor type. So the factor that affect detail of image first is motion. So it can be voluntary or involuntary. best controlled by short exposure time and use careful instruction to the patient. Suspension of patient respiration, so asking patient to breathe in or breathe out and stay still when you are exposing to the patient, expose radiation to the patient. And immobilization device, use immobilization device to avoid movement from patients. SID also contribute to detail. The more further the source of X-ray, give you the detail of objects, and the near one give you the magnified images and large penumbra, which is not very detailed. Okay, focus spot also affect detail of image. The area of anode target by electron is described as the actual focus spot area, whereas the rectangular area projected downwards to produce an X-ray field is known as the effective focus. So the small focal spot given you better detail compared to large focal spot. So OID also contribute to the detail. So radiographer must position patient closest to the film. So the closest to the film, the object to the film, give you the more detail compared to far away from the image receptor. Image receptor, defined as the device that receives the energy of the X-ray beam and form the image of the body parts. Common types of image receptor is cassette, image plate, and direct radiography detector. So this also contribute to the detail in radiograph. Number 4, factor affecting the image quality refer to a variation in size of shape of the image in comparison to the object. We call it distortion. There is two types of distortion. First one is according to the size or according to the shape. Second one. And size distortion can be magnification, and shape distortion can be foreshortening and elongation. So the factors influencing distortion is SID, OID, beam angulation, body part beam alignment. How SID influence the distortion? A longer SID decrease magnification, and a shorter SID increase magnification. Number 2 is OID. OID, object to image distance. If source is kept constant, OID will affect magnification. As OID decrease, so magnification also decrease. The farther the object is from the film, the more magnification to the images. Beam angulation also contribute to the distortion. As example, A here, a true shape of anatomy, and B and C, shape distortion, elongation of part, depending whether you angle up or angle down. This is the example of foreshortening, shape distortion because of body part or beam alignment. So we already finished the audit, radiograph, and roles of radiographers. A little bit knowledge about the factors influencing the image quality. Now we go to the suggestion for improvement about audit and image production. I believe that education and learning process is the way to improve image quality. As a radiographer, film critic session with radiologists or specialists from requesting clinic, CME, course or conferences, workshop, research day, discussion improvement and preventive actions to be taken to meet the quality standard, and two ways of communication between clinic and X-ray department is the best way how we improve the quality. In this part, I will share you the experience from HKL. This is the example of film critic session with radiologists. The film being rejected, bring to this area to call radiographer to critique what is the reason the film being rejected. And the radiologist will guide and will teach radiographers to improve the quality of radiographs. There is also film critic session with senior radiographers in the evening. So we also can teach students and new radiographers, and to improve the services, how to perform proper positioning to the patients, to reduce rejects and retake of radiography. If we have unfamiliar procedure examination, requesting unit requests, so we call them, like orthopedic specialists, to give us CME, to guide us what actually they want to see and what how we can perform to give a better quality of images. We also need to arrange for workshop. We do different group. We give the situation, we give the scenario, so how they improve, how they perform, so they share with other radiographer, the senior one, the junior one, they share their own method, so which one is the best. So this is the opportunity actually to get an idea, to improve the skills, to improve the quality of producing images. Okay, after we call the specialist, we conduct the CME, and then we need to know whether radiographer really understand, because we are technical person. So the workshop, the training process is important. So the senior one, training the junior one to do a special examination, to improve the knowledge and to give new knowledge to the junior. We also can share with other in a poster guideline, so that other radiographers can refer the protocol, the procedure, how to perform the examination, special examination, which is very rare, ordered by the specialist. We need to perform discussion on improvement in and preventive actions to be taken, to classify the image, to determine the cause of the problem, and recommended the corrective action. In summary, we start with introduction to radiology audit, quadrille placement, QAP in radiology, reject and retake reason and causes, reference guideline, journal and article, the example of clinical audit and learning materials. And secondly, we go to the roles of radiographer on high image quality production. So with the international patient safety goals, SOP book, checking the correct information, producing guideline material factors affecting image quality, and the thirdly, we go for the suggestion for improvement with education and learning process, the art of film critic, CME courses, conference, workshop, research day, discussion, and communication. So with that, sum up with my topic today's. Hope you enjoy the courses. And next, the reference for my presentation. That's all from me, and thank you for listening. If you have any question, you can email me.